This week on Core Ultrasound Image Review, we have a recorded lecture that I gave for our residency didactic where we did some image review there. The focus on this image review is actually going to be on procedures. I walk you through some good examples of ultrasound guided IVs and my top tips for how to make sure that you are successful. Additionally, we're going to talk about a few nerve blocks. Ulnar nerve block, and then one of my favorite ones I've been doing recently, which is the serratus anterior block. It does really well. Traditionally, it's for rib fractures, but I've used it a few times for axillary abscesses, which traditionally are very difficult to adequately anesthetize. Then I spend a little bit of time talking about AAAs and joint aspirations, which are something that is definitely within our wheelhouse that I think sometimes we're reluctant to do, but with ultrasound, it's pretty easy. Before I show you the recording, make sure to check out courses.coreultrasound.com for CastleFest 2020 if you want to have access to those great recorded lectures that we have there. And then if you are interested in an online fellowship, check out ultrasoundleadershipacademy.com. Image review. Let's do this one. This is a very exciting ultrasound guided IV. So what's really cool about this ultrasound guided IV is first, she's showing me that she is walking the tip of the IV down the vein. That's why it's in the middle and then it kind of disappears and then it pops up again in the middle, pops up. She's getting that catheter more in the vein, which is great. And the other thing that's really cool is you see this structure right here? This right here is a median nerve. You do not want to go through the median nerve. It hurts. It causes comorbidities. She, if you can see the kind of path, she came in this way knowing that she had to avoid this, and it's just perfect. Now let's do a little bit of a review on ultrasound guided IVs. Sometimes your patients are going to have this. Very, very twirly veins. Very, very twirly veins. These, you can still cannulate these very twirly veins by planning your attack. What you can do is you can say, you know what? Right here is where I want to cannulate my vein. But there's a little bit of a distance between here and here that's going to take me to get there. So what I'm going to do is I'm actually going to start my cannulation coming right here a little further back when it looks like I'm not in an advantageous spot. Poke right there, and then as you move proximally to the patient with your IV, aim to get it right here. So planning ahead is something that is a little difficult to do if you're starting out, but if you do that, you're able to cannulate a lot easier some of these swirly veins. This is a reason right here why I don't recommend placing ultrasound guided IVs in the brachial or the antecubital fossa. The reason for that is that in the antecubital fossa, the vein depth is usually going from a little bit deeper to a little more shallow. This right here is the vein, and I'm coming at it this way right here, and you can see that it is impossible for me to actually cannulate that IV. You see right here, the cannula is not wanting to go this basically more than a right angle up this vein. So I usually go above the antebrachial, the antecubital area, or below the antecubital area to avoid this issue. This right here is an example of an IV that will blow. This very likely will blow. Now, great ultrasound guided IV. This is the vein right here. But you see all of this catheter is in the subcutaneous tissue, and there's like a little tip of it over here. If you have a patient that needs an ultrasound guided IV for a CT scan, I would not recommend shooting high pressured contrast through this particular IV. To avoid this, what I would do is, first off, I don't know if this is the case, but I would make sure always to use the longer IV catheter. And I would actually come in, I'm exaggerating, but I would come in at a much sharper angle and then get into the vein over here so that maybe from here on, it's actually in the vein. More of the catheter in the vein will make it less likely to pop out. Remember, this is your kit for ultrasound guided IVs. Use the long catheter, use these little gel packs. Don't use the bottle gel. The bottle gel is not necessarily sterile, even if it's been in an unopened bottle. You need a tegaderm and another tegaderm. You need a tegaderm for the probe and a tegaderm for the skin. Make sure that you have some gauze to wipe off the gel. Now, as far as where to place these, I had a discussion, I don't remember with who, but it was someone who was relatively experienced. And they were mentioning that basically every time they're doing an ultrasound guided IV, they always go for the upper arm, every single time. That's definitely a way to do it. However, I will tell you that especially in our patients that are, shall we say, fluffy, have a little more adiposity, and maybe are a little darker skinned, these patients often have veins in the forearm that we can place like 14s in. They have huge forearm veins, but because of their adiposity, because the veins can't be seen, they are unable to be located by landmark means. So the way that I do this is first thing I do is I place the tourniquet super high up in the arm, basically right beneath the deltoid, and I clean from the tourniquet all the way down to the mid forearm. I don't look first because it just wastes time. There's usually something that I can cannulate. I start in the forearm, and then if I don't find anything in the forearm, then I will look in the upper arm. The reason why I do it this way is because A, oftentimes patients have great forearm veins. They hurt less, they're less uncomfortable. However, a lot of these patients that are difficult IV access patients continue to be difficult IV access patients when they leave your hospital. So what you should consider doing, especially after you've had a couple of these ultrasound guided IVs under your belt, consider that every time that you poke a vein, that vein probably becomes less likely to be cannulatable in the future. Try to be good stewards of your patient's veins by not always just going for the basilic. The basilic is where PICC lines go, usually. Try to save the basilic vein for if they need a PICC line in the future. Go for those forearm veins. Try the cephalic vein on the lateral aspect of the arm. But if you have nothing else, it's okay to go for that basilic or that high brachial. Let's talk quickly about the technique behind ultrasound guided IVs. You always want to make sure that you know where that needle tip is. The ultrasound machine cannot tell the difference between the needle tip and the needle shaft. So here's a high-tech representation I made. Ultrasound transducer, needle. This is the skin. This green thing is the ultrasound beam. This is the vein, and here's the ultrasound image over here. What you do is you poke the skin and you advance the needle until you first see the hyperechoic dot of the IV. As soon as you see that hyperechoic dot, you are going to stop the needle, then move your transducer away until the needle tip disappears, and then you can move your needle. That's why I call it sequential needle tip tracking, and so on and so forth. That way you always know exactly where that needle tip is. All right. Once you're in the vein, what you can do is you can do this to just make sure that that is in fact the tip, and it's actually not all the way down here. Here's an example of actually performing an ultrasound guided IV. Now on this one, what I'm doing is I'm actually trying to find the path of the vein, and notice it is very perpendicular on this patient's arm. My initial stick is going to be pretty sharp, and then I'm going to flatten it out. Now, it has to be kind of sharp initially to get actually in the skin. Sometimes when patients have floppy skin and you go at too shallow of an angle, you won't be like puncturing the skin. You'll just be like scraping the top of the skin, excuse me. And I'm doing very small movements over here. I'm doing my sequential needle tip tracking, readjusting my needle until I get into the center of that vein. And notice I'm moving with very small movements here, like very precise movements. And then what I like to do is afterwards, I turn it into the long axis to make sure that I'm not poking through that back wall as I slide the catheter in. I call this the 2-axis technique. It's my preferred way to get these ultrasound guided IVs. A little bloody there. Sorry about that. When you tape, make sure that you place the sterile tegaderm on first and then put the tape on. I see some of the residents sometimes do the tape first. The nurses do that sometimes too, but that's not correct. The tape is like rolling around in their pant leg. They handled a patient with C. diff and then grab the tape. You know what I mean? Like it's not clean. So you want to have that on the outside of the tegaderm. So you put the tegaderm first, and then what I do is I put kind of like a reverse chevron. So I stick a skinny piece of tape, sticky side up, underneath the tubing, the extension tubing, and then fold it over to kind of anchor it in place. And then I will tape just like this. You just spent all this time placing this ultrasound guided IV. I tape it kind of aggressively like you see here because I don't want to have to do it again. This, I'm so excited. I just like found this on QA and I looked at who it was and very excited that this was done. This right here is a needle, a great view of the needle in the long axis. And this right here is the median nerve. We have the superficial flexors up here. We have the deep flexors down here. Is they're infiltrating the area right above that nerve. And then they're backing up and going beneath the nerve to create a little kind of donut of anesthetic. So anesthetic and then the donut hole would be this nerve. It's so good. It made me so happy. And they said the block worked very well. And here you can see that they're infiltrating the area around. So here at the end here, let's pause it and go all the way to the end here. We see a donut around this nerve. Remember, you don't want to get inside the nerve. You want to get in the fascial plane below and above that nerve to surround it. Quick review on median nerve blocks. The median nerve supplies the sensory innervation for all of this area. So it's a pretty powerful block. Most of the times when I'm doing hand blocks, I'm doing them for the using the ulnar nerve block or the median nerve block because the radial is just like a small part of the sensory innervation of the hand. So if you're going to learn 2 nerve blocks, learn the median, learn the radial. These are a couple of indications. This is not the patient that this particular block was used for. But over here, we have an abscess in the thenar eminence. You can see pus draining already, and here's a laceration on the thenar eminence that I have used median nerve blocks in the past. The probe placement is going to be probably mid-arm would be the best place to place it. You have these superficial and these deep branches of the median nerve, and they branch off at a variable distance from the wrist. So if you go up on the forearm, you're definitely going to capture the nerve before it splits, A, and B, as you get closer to the hand, it hurts a little bit more. You have more pain receptors closer to the hand. So hurts a little bit less, more likely to get a complete block. Here is the technique. I tell some of you guys this, but when I was a fellow, I really wanted to like understand these nerve blocks better because I think they're so important. And so I had my fellowship director, Matt Dawson, do basically every single block on me. And here is a median nerve block. Be really careful over here with this beady boy right there. That is my radial artery. You definitely, if you're coming at it from a in-plane approach, definitely be able to identify this and make sure that you're going underneath it. All right. So here is his needle placement. And I'll go to the next image right here. And you'll see that needle come in. It's obviously, my heart rate wasn't like 200. I sped it up, obviously. And here you can see the needle coming in. And here is that nerve. And he's going to start injecting right underneath it right here to create anesthetic within that fascial plane. Now, what I usually do instead of doing this in the long axis is I will do this in the short axis. There's one of 2 nerve blocks that I do in the short axis. The reason why I do it in the short axis is because when you come at it laterally, you're actually going through a lot more tissue. And I will tell you, when I got this block done to me, you see this guy right here? This is a tendon. And when Matt went through that tendon, that was the part. See right here, you can see it kind of like stretching a little bit right there, and then he'll pop past it. Wait for it. Right there, he pops past it. I will tell you that out of all of the blocks he did, this is the one that hurt the most because of him going through a tendon, which was tricky. What I prefer to do is actually a short axis technique. So here is the median nerve. I come at it basically like I'm doing an ultrasound guided IV, and I'll track it down right here. And here you can see my needle right next to it. I'm doing some hydrodissection to get that fluid around that median nerve. So that nice little donut around that median nerve. This one right here, I'm so excited about this one because this is one that is one of my favorite blocks to do. So excited about this block. It's very helpful for rib fractures and axillary abscesses, which are 2 things that are very difficult to pain control. So you guys see right here, the needle, it's a little out of plane for a second, but we find it. You see this anesthetic right here. Here's the needle tip. See that anesthetic right there? This is a plane block. I will tell you that this right here is a rib, and you can see the pleura down here. Does anyone have any idea what this block is called? I'm going to assume that everybody knows. It's called a serratus anterior block. This right here is the serratus. And what you're trying to do is you're trying to inject anesthetic in the plane above or below, but I usually do above, of the serratus anterior. And it blocks the entire, mostly the lateral, but a little bit the anterior chest wall. Great for rib fractures, and it does the axilla as well. So this is an example of where to go. You can actually see on this individual here, you can see the serratus muscle here, here, and here. Your place that you're going to inject is about the mid-axillary line at like the T5-ish level, which ends up being right around where the nipple is, maybe right a little bit lower to where the nipple is. That's what your injection is. The exact site doesn't matter all that much. If you're like, maybe you're T6 instead of T5, that doesn't matter because you're doing a relatively large volume block in a plain area. So it's not like a specific area. You're going to just like infiltrate anesthetic everywhere. You can, if your patient's in a lot of pain, you can have them laying on their back. That can work, but best case scenario, you're having them lay on their side, and this is how you're doing your needle placement for that serratus block. And here's another example of a serratus block. This right here is a serratus muscle. It's basically the muscle that's on top of the ribs. It's right there, highlighted in red, and you advance that needle until you get to the fascial plane that is in right on top of the serratus. It's interesting because they've done studies of above or deep to the serratus, and they both do pretty much the same. So it's probably safer to just stay above. So I have this needle here, and now I'm injecting fluid in the fascial plane in between the serratus and the muscle above it. Now, one thing that you should do, notice, let's back it up just a little bit right here. Notice my path. So this is assuming that my patient does not already have a pneumothorax. So if they already have a pneumothorax, it doesn't really matter all that much. But if all they have is broken ribs, or you're doing this for abscess, right here is a rib. And notice my path is going directly towards that rib. So if the patient coughs or jumps or I slip and the needle goes a little bit too far, I'm going to poke the rib. I'm not going to poke the pleura. And that's actually like super important. You don't want to create a iatrogenic pneumothorax. Don't create an iatrogenic pneumothorax. Next, ultrasound image. Again, super, you guys know how I am. I'm so excited about ultrasound. What this is an ankle effusion tap. So right here is probably the tibia, and right here is probably the talus right here. And this is an ankle effusion. And here is that needle going right into that ankle effusion. We can do taps, you guys. We can do hip taps. We can do knees. We can do ankles. We can do these. I would suggest doing these all with ultrasound because it is significantly more accurate. And it's just like with ultrasound guided IVs versus landmarks. With ultrasound guided IVs, you're like digging around sometimes, which hurts more. Whereas with an ultrasound guided IV, you know exactly the path. It's like a straight line down. It's the same thing with these arthrocentesis. You're not like poking around like you do for like an LP trying to find the spot. With the ultrasound, you can directly visualize that fluid and make sure that that needle goes directly inside that fluid. Here's an example of doing one on a patient with a probe placement. When I'm doing these, I generally am full sterile because I don't want to accidentally introduce stuff into the joint space. And by full sterile, I'm not like in a gown and a bouffant cap or whatever, but I'm using the sterile gloves and I'm using the transducer sheath cover as well. This is that same image that we saw before. Here is the tibia, and this is the talus right here. And you can see that it's very easy to get visualization of that actually relatively small effusion, at least a tap, with that ultrasound. So I'm poking right there, increasing my angle, and you'll be able to see over here the needle come into view. So I'm a little off axis right here, but I move my transducer a little bit, and you can see right here, I'm going to poke into that space and be able to drain some pretty gross fluid in there. This right here, pretty sweet. What do you guys think? Oh my goodness. Quick question, you guys. Would I measure, if I was measuring this massive aorta, would I measure from here to here? We will measure from here to like out here somewhere. We've got to measure outer wall to outer wall. This is a massive aorta. Yes, good job, Wes. It's a McConnell sign. Right side of the heart over here. That heart is popping. Right heart strain. Yeah, Robin, you're totally right. This is the right heart over here. This is the left heart. This is acute right heart strain. You see this right here? You see how this apex is hyperkinetic relative to out here? This is called a McConnell sign, and this is indicative of acute right heart strain. Notice I didn't say this is indicative of a PE. I said this is indicative of acute right heart strain. The reason for that is that if you take all echoes that are ever done in a hospital, McConnell sign is actually not specific for a PE. Because it happens in RVMIs, it happens when you have acute cor pulmonale as well, it can cause it. However, if you have a patient in whom you suspect they have a PE and you look for a McConnell sign, the McConnell sign in that situation is specific. It's all about how you apply the test. And then I wanted to show you another clip over here. This is chronic RV enlargement. You see here that the wall of the RV is really thick. This right atrium is huge. I'm not seeing any McConnell sign. This is chronic right heart enlargement. If you can, what you can do, there's a bunch of things you can do to differentiate from chronic and acute right heart strain, but the easiest is probably going to be looking at the thickness of the RV wall. If the thickness of the RV wall is greater than 0.5 centimeters, it's more likely to be chronic enlargement. So with ultrasound guided IVs, make sure that you choose the vein correctly. I usually start in the forearm just to save the upper arms. With nerve blocks, I usually do them in plane, although with the median nerve block, I'll sometimes do it out of plane. With serratus blocks, make sure that your needle trajectory is going directly towards a rib, especially if your patient doesn't have a pneumothorax, because you don't want to be the cause of an iatrogenic pneumothorax. For a AAA, make sure that you measure outer wall to outer wall, not inner lumen to inner lumen. And with joint aspirations, it's pretty easy. Just go for the biggest pocket there to make sure that you are the most successful. Hope to hear from you soon, and happy scanning.